So we're just at the very fag end of the entire session, and it's good to see there are people who are still there. After Professor Rara's talk on fixation, it's time to sort of turn the attention to something or situations where you cannot fix, and perhaps a total elbow arthroplasty would do better for those patients. So mechanism of trauma, as you see, these are completely different people. The lady on the left who needs a walker to walk around, and then the guy who's on an MTB, both of them can have a supracondylar, intercondylar elbow fracture, but with a completely different mechanism. That guy is going to have a massive fall, while this lady is just going to slip in the bathroom or something and get that similar kind of fracture. And therefore, the treatment for them would also be different. Now, having said that, look at this particular injury in a lady who is 60 something, very active woman. And this was a little bit before the era of elbow arthroplasty, in my hands at least. Now, so very low comminuted supracondylar fracture, perhaps be left alone, but she said, I'm very active, I need my mobility. And at that time, before the era of locking plates as well, what we did was multiple bicolumnar fixation. So on either column, we did a 90-90 fixation. So on the medial as well as the lateral column, this was the fixation that we could achieve, in spite of the fact that this is all that was there in the distal column. The bone were not that bad. This was done in 2004, so that's nearly 13, 14 years ago. And then that went on to have an excellent union, and she continued to have a wonderful range of motion and function in this really old lady who is now, this was in 2010, so this is 6 years after the surgery, and now she is nearly 13 years post-op. She's not come back even for getting her screws or implants removed. So it is not in lieu of a fixable fracture. So I'm not trying to promote elbow arthroplasty. I'm not going to oversell it. Okay, so the idea is to fix these fractures as long as you can, irrespective of the age of the patient, but then at some point in time you need to balance the pros and cons of fixation versus something different. But the same lady, you open up and then this is what you get, and obviously this is not fixable. And sometimes, as I mentioned during the case presentation, that it's impossible to find this out preoperatively on X-rays, and therefore that's the importance of CT scan, because if you're going to already do an olecranon osteotomy, then you are in a bit of a problem, because it's difficult to do a total elbow arthroplasty in the presence of an acutely done ulnar osteotomy. So that's the importance of CT, and especially in these elderly. It will tell you what to do and probably what not to do. Now, they have a wide variety of spectrum. Now, this is a relatively innocuous looking transverse fracture. However, I have noticed, and I would urge you to notice and probably send these X-rays to me by WhatsApp, there are transverse low intercondylar or transcondylar transfossa fracture is the hallmark of an arthritic elbow. Okay, and it's a stiff elbow, and this is where most of these fractures happen in arthritic elbows. I'll show you some cases where you have to suspect that a fracture like this in somebody who is 60 or above is going to have a likelihood of an arthritic elbow. And then unfortunately we do still end up with situations like this in this day and age, when with improper initial fixation you end up with situations where you might have to salvage the elbow joint, and I think the more logical way is to replace this. Again, the same situations. And this was a lady who was working in Sudan, and she came to us with this situation with literally no distal humerus left. She was working with the United Nations, and she wanted some kind of a function back. So she came, and I'll just show you what we did for her. So these are wide array of presentation in these patients. And I presented this, I published this way back in 2003 along with some of my colleagues from the US, and there at that time it was still a part of a controversy in total elbow arthroplasty. So doing total elbow arthroplasties for fractures 15, 12 years, 13 years ago was still considered to be a controversy. I think things have changed right now, and I think it's definitely a valid form of treatment when it comes to the elderly osteoporotic fractures. So the first literature was in 1997 by Professor Bernie Mori and Cobb, where they did acute total elbow arthroplasties in people over 70 years of age with an average of 72, and they concluded that vast majority of these patients, nearly 70% of them had excellent results and the rest had good results. So there was no fair or poor, and I think they considered that a total elbow arthroplasty is a viable option for trauma situations as well. So this is the first literature suggesting that we should do, or we can do, total elbow arthroplasty for acute fractures. So in my practice, the indications are, number one, we're only talking about the old people. We are not talking about somebody who's 35, irrespective of the kind of fracture he or she has. So complex fractures in low demand patients that are not amenable to fixation with pre-existing arthrosis in the elderly. So this is my list of indications. So this was the case, again, you know, did not look that bad, but while opening up, everything started to come out, and then we did have a salvage situation for her. We anticipated something like this happening. She had a pre-op CT scan, and she ended up with a total elbow arthroplasty. So again, as I said, beware of the transverse transfossa fracture. Now, this is a hallmark of an arthritic joint. Can you look at this elbow? This elbow is completely arthritic. Okay, and not only are these fractures a hallmark of an arthritic elbow, they are very resistant to union. So one can imagine that if it was a stiff or an arthritic joint, just like probably some of our knee colleagues talk about stress fractures in the proximal tibia, secondary to an osteoarthritic knee, which are quite resistant to osteosynthesis. Similarly, this may look innocuous. You may try to say, okay, she's an old lady, why don't I put a few wires? This is not going to heal. So how do we do that? There are some approaches. One is called the triceps reflecting approach, or the Bryan and Mori approach, triceps splitting approach, which I quite commonly use. And then there is the new triceps on approach, which is quite useful for acute fractures. So you just keep the triceps in continuity on the humeral side as well as on the olecranon, and just fish out all the fragments underneath it and do a total elbow arthroplasty. So these are the three commonly used approaches for total elbow arthroplasty. You could do a lateral position, or you could just do an arm across chest. And this is the triceps reflecting approach. Sorry about the quality of the slide. I think it looks a little bit red. But basically, this peels off the triceps off of the olecranon on one of the sides, and then you expose the distal humerus and the ulna. You can definitely see the amount of comminution that you have here. And then there are various systems which are available. For trauma, we do what we call a linked prosthesis, which means that there is a linkage between the humeral and the ulnar component. There is a pin here which sort of clicks into it. These are polyethylene bushings. So these are there around the humeral component as well as within the ulnar component as well. That's the flange. A long flange prosthesis is preferable, especially when you have an absent distal humerus, because it provides an anterior cortical support. This also provides about 12 degrees of varus valgus jog, you know, replicating some kind of natural movement happening at the elbow as well. This is my preferred approach. I do a triceps central split, so I just go all the way right down the center, and I take the triceps off on the medial and the lateral side. This is nothing new. It's a very old approach described by Urbaniak really many years ago, and then popularized by some of the elbow surgeons to do a total elbow arthroplasty. And again, this was a salvage situation. You can see that this was a diabetic woman with a 3-week-old fracture with really soft bone, and we did a primary total elbow for her. When you do that, you actually literally excise the entire distal humerus. There's no point in keeping anything. It's a linked prosthesis. You do not need the columns. That's the humerus just at the level of the olecranon fossa. That's your radius, and that's the ulna. And then you end up doing that. Obviously, you need to have isolate the ulnar nerve. That's the linkage of the system. And you want to make sure that there is no impingement in full flexion as well as extension, so that the patient can be mobilized fairly early without any problems. So you do need to release the capsule from the front and the back, as well as any extra pieces of bone that might be lying around, to make sure that you have an unimpeded range of motion. Sometimes in very soft bones, especially around the ulna, we do what is called a prophylactic wiring. So just like any other bone, you know, if you fear a blowout, you just do a prophylactic wiring around it before you start making your entry into the ulna, and you know, that serves us well. Sometimes I just leave it behind without any problems at all. Again, this was part of our publication a long time ago in Journal of Hand Therapy, and it's a good salvage option for non-unions. either failed treatment, failed operative treatment, or perhaps a failed conservative treatment, and can be done successfully. So again, look at this fracture pattern, a straight horizontal fracture through the olecranon fossa in the presence of rheumatoid arthritis. So just something for you to think about when you see a transverse fracture in the elderly, that there may be a bad joint below, and there was no point in trying to fix this. This patient was painful anyway, so we straight ahead went and did a total elbow arthroplasty for her or him, and this is a final result. Long time before that, we used to try and salvage some bone, but it did not matter because of the link prosthesis. So we don't put in the screws or something, because then it looks like a non-union forever, you know. So there's no point in keeping it. So we remove the entire articular chunk in most of these patients. So this is what I was talking about, distal humerus hemiarthroplasty. So in the last 5 to 10 years in the Western world, this has picked up quite aggressively, especially in a population under 50. So you do not want a total elbow, but then a hemiarthroplasty can be done in some of the bad kind of articular shear fractures that we talked about during the entire day. But this requires the presence of condyles, because the stability is achieved by the collateral ligaments. So in this you have to have osteosynthesis along with distal humeral hemiarthroplasty. So this is an attractive option, and hopefully we should be able to do it in a few years from now. In salvage situations, in non-unions which are not amenable to fixation, or in situations where there is significant bone loss, as in this case, you know, we salvage that with a total elbow arthroplasty. And rehabilitation of the triceps is very essential, because this lady had multiple surgeries and a very poor triceps. So the functioning is quite dependent on the triceps when you're talking about a total elbow arthroplasty. Again, multiple failed surgeries. In a relatively young woman in her mid-50s, this was the situation here. There was nothing to salvage or fix, so we just removed the articular block and did the same thing again for her. In most of the situations, we tried to use a long flange with a bone graft underneath this flange to support the anterior column or the anterior cortex, and that was a range of motion after about a year or so. So not perfect, but she's painless and she's quite active. So current status, I think it's a viable option for people over 65 years of age. Outcomes, according to the literature, are more predictable in the elderly group when you consider against ORIF. Doing a primary total elbow may decrease the need of revision in these patients, and short-term results are definitely in the favor of total elbow arthroplasty in acute fractures. So the drawbacks are we don't have long-term data. We don't have these implants lasting 10 years, 15 years for us to tell that they are good or they are bad. There are lifelong weight restrictions. We do not allow somebody to have a single lift of more than 5 kilos per day. Okay, and maximum allowance is about 11 pounds, and that also, that's 5 kilos once a day. Otherwise, we just ask them to use the elbow in activities of daily living. In the Western world, they allow people to drive a four-wheeler, but two-wheeler is out of question because of the amount of load it would put on the elbow. So people who are obese or people who are walking aid dependent. So again, this is a little bit of a dichotomy. So a lot of these patients would need some walking aids, and then, you know, it's a relative contraindication to do a total elbow. Infection, even as a complication, is obviously devastating, just like in any other arthroplasty. And mind you, the rate of infection in total elbows is slightly higher than hips, knees and shoulders. So this is something to just keep in mind. And this has the potential to be the easy way out, you know, rather than putting 3 or 4 plates, why don't I just, you know, replace the elbow? So I think that's a potential drawback. So there is no evidence as of now as to which one is better. So in fixations which work, they have the same scores as arthroplasty. Okay, so the idea is to make something work. So these are all various comparative studies over the last decade or so, and most of them suggest that the rate of complication is lower in total elbow arthroplasty as compared to ORIF in elderly patients. Again, some more studies. The maximum number still comes from the Mayo Clinic by Bernie Mori, and then everybody else has relatively fewer numbers. You know, somebody has 7, 10, another 7. So it's not that it's people are having large numbers, except from the apart from the originators. So again, this was a patient, you know, where it was a failed fixation, but this was his size, and he doesn't get a total elbow. So he needs to live with an excision arthroplasty. Thank you very much for your attention.